Dr. SREENI will be talking on cataract surgery and topical anesthesia, especially when it turns Stormy. What next?
Thank you, Umesh. And once again, good afternoon, everyone. See, but mostly we go for topical anesthesia cataract surgeries these days, and either under uh, topical anesthesia or even under block, there are situations where the patient turns uncooperative. Under topical anesthesia, I mean, there is no reason. The patient is just uncooperative. The patient is not able to look directly up and keeps on moving. So that is one of the causes why you get an uncooperative patient on table. And you feel, let's see, the patient becomes uncooperative. One of the reasons, I mean, he might be actually a cooperative patient, when he might turn uncooperative because our topical medications has not given enough uh, analgesia for him, and you touch his conjunctiva or wherever, he gets a pain and he keeps moving. So that is one. The other one, the most difficult to manage, is claustrophobia. I mean, you might have had at least one patient in your career who had claustrophobia and you had to struggle with that. The other one is patients, everything goes up fine. The patient starts coughing because of breathlessness. I'll come to all this. So let's first see this patient. The patient obviously was taken up for cataract surgery under topical anesthesia. See, from the beginning, the patient was not really cooperative at all. But most of the times, I'm able to get through with these patients. Like after some time, they start cooperating. So this patient, I thought, okay, I'll be able to do it, and so the section side port both were made, and so because holding the globe at 2 points, the globe was stable. But then again, he started rolling his eyes about. So when I because when I was sure that it's going to go in many directions, and I'm going to lose the globe, so I decided to stain the capsule, and so till then, okay, like he was okay there. Then I just trying to remove that trypan blue and all. Then again, he's absolutely not cooperating, because for me to do a proper access, the eyeball has to be stable. Otherwise, definitely it's going to go to the periphery. Then so this is a situation, and see, there are two options here for me. Uh, so one is to give a block itself, peribaba block. But peribaba block here is going to push the globe. You need at least 5 ml of anesthetic there, and effectively open globe. Then see, the better choice is, it's not that I feel like it is a subtenance anesthesia, and so you make a nick in the infratemporal quadrant in the conjunctiva, and you go in with that special needle for subtenance anesthesia, go hugging the globe, go till you meet the hub there, then you inject. See, the two movements have to be smooth here. The movement of the cannula in, and the injection also should be smooth. Then only you're sure that you're in the right plane. So the analgesia happens almost immediately. But the echinacea, for the total echinacea to take over, it might take quite at least 3, 4, 5 minutes. Literature says 10 minutes. But within a minute, the movement lessens, and you'll be able to complete the cataract surgery. And so the only issue here is that you might have some subconjunctival hemorrhage here, but it goes off in 1-2 days, when your surgery goes off very safely. So this Tenon's capsule actually is anteriorly attached to the conjunctiva, and fuses at the level of the limb. I'll tell you why I mentioned that. And this is from the literature. They say the nick in the conjunctiva has to be 5 to 10 millimeter in the infranasal limb and can be as far inferior in the fornix depending on the patient anatomy. But I've found that, see, that I just repeat the procedure. I've found that the more posterior you go, the lesser chance that you get the correct plane. So I don't go really posterior for the neck. It's about 5 millimeter or so from the limbus, and it's like a hugging move there. On the cannula hugs the sclera and goes behind, and the amount of the lidocaine that is used, I use only 2 ml. They say 5 ml is good for echinacea, but 2 ml I feel it's good enough. I don't want see, when the globe is open, I don't want more volume of fluid there pushing the globe. So these are the different cannulas. You can see different gauges are there, different points where the openings are there on the cannula through which the lidocaine comes out. Whichever it is, it works. 1 port, 2 port, 3 port. See, even 1 port it diffuses, 2 port it diffuses. It doesn't matter. I'm just a bit worried about the thinner ones, 23 G ones. It might not perforate the globe, but it looks like a normal needle. So I go for a 19 G or maximum 21 G cannula for this. No financial interest at all. This is from Episamia, and this is from Epsilon, and so just this is it. This is the point where I nick the conjunctiva, and I can see that it's going in smoothly. And if it needs some resistance, it's manipulated around. And when you start injecting, also if you get some resistance, just manipulate it. And if it is not going in, then come out, repeat it. You make a nick somewhere else and do the procedures. So this is and complications. I mean, effectively no complications are possible. The possible complications are neuropuncture, brainstem anesthesia, globe puncture, intravascular injection. With this blunt tip, it is not possible. The only thing is might have some bleeding wherever you have nicked the conjunctiva. Coming to claustrophobia, these are the most difficult patients. See, when it happened to me first, I thought, I'm good enough. See, I take only 5 minutes or even less for phaco, and I'll be able to just talk to the patient and do it. No, I've burned my finger many times. If the patient say, when you put the drape, he or she says, no, then I just postpone the patient. See, like I mean, so many cases to be done in a day. You're not going to talk to each patient with pre-anesthetic checkup and everything that you do for head and neck surgeries and all that. We don't usually do that, right? So on table, and the patient is also not aware. They might have never slept with the bed sheet on their face. So this is the first time this is happening, and it happens on table. So you can't blame them. So if that happens, I just postpone the case. I don't do that case. I don't attempt it. I might just try it out in the preparation room. I tell the nurses to just put it again. But nearly 100% of the cases, they don't agree. Then I talk to my anesthetist and counsel the patient. And so many times, so these are the tools to detect and effectively manage claustrophobia. One, see this on hindsight, like you know that he's claustrophobic, you find out, okay, a history of claustrophobia, counseling with the attention, anxiety provoking factors, trial run. People say you do it in the OPD, but I do it in the, let them have the feel of the OT. I do it in the preparation room, and give them a choice of general anesthesia or whatever anesthesia other than a block and a topical. This is very important. See, those who are scared, they want to hold somebody's hand. They tell, sister, you be there, hold my hand. So let somebody be there. Music they say, I don't have a music system, and you have mobile, but I've never tried that. So it's hand holding that, and obviously, like, try not to have any complications. Everyone has a particular surgical time, and so reduce the surgical time to a minimum. Constantly talk to the patient. Normally, I don't. I just do it, and at the end, I say, everything is fine. But in these cases, I just keep talking to them. And another thing, like, there's this opaque drape. It doesn't give them the view of what is there outside. So the other eye also give that clear drape so that they can see, tent up the drape. So these are the things that we do, and this is very important. If the patient coughs midway through the surgery, you should always consider pulmonary edema. Stop right there. Just ask the patient if he or she is feeling uncomfortable. It is pulmonary edema. You'll have to intervene wherever you are. You have done the chop, and it is there. It doesn't matter. Stop. Take the patient. Give the patient to the anesthetist. F-colon, whatever, Lasix, everything given. Save the patient's life, and then take up the patient for the surgery later. They'll be actually very thankful to us. They won't blame us for doing half the surgery. So this is basically on what I could think about the sort of uncooperative patients that I've had in my OT. This is it. Umesh.
Yeah, thank you, Srini. That was very comprehensively spoken. I think the take-home message here would be that the best way of avoiding these would be appropriate preoperative identification of these patients. Uncooperative topical, you can identify them when you're doing your slit lamp examination, when you're doing your A scans, when you're doing your indirect ophthalmology, you can definitely know. And by giving proper counseling, most of them will converted into topical, or if you know well in advance, you can always shift them to blocks. And regarding claustrophobia, I think we also see a lot of such cases. One prevention thing that we are doing is, for such patients who have claustrophobia, we ask them to sleep in the block room and with the drape on, and ask them to sleep for 5 minutes without any procedure. So most of them by that time get used to it. And in severe cases, we have done anesthetist around, obviously, with midazolam, and that definitely helps because it's a 10-15 minute surgery. Midazolam definitely helps. Please talk to your anesthetist. They'll be able to do a good job. Thank you,
I want
Srini.
just a few points to add on to that is very similar to how Srini did give his subtenons. You could also make a small nick after anesthetizing the culdivisac and in the inferior fornix, and just pass your IV cannula here, what you put on, and then you have at the end, and you can keep injecting and reinforcing. It does go into your subtenon space, and there you do have the freedom of giving in more amount of anesthetic if you need to reinforce subsequently. That's one point. You also have Thornton fixation rings of different sizes with which you can just hold the globe at the limbus here, and that also helps you to stabilize the globe in these patients. One. And again, claustrophobic patients, we do have that particular rod which is attached to our table, and that lifts your surgical drape a little higher and gives space and allows them. Yeah.
But even that,
Even with that, yes, I do agree. They do need a lot of reinforcing in terms of emotional support.
feel of something blocking their view and everything. So